Hello, my name is Lynn Canali. This is the presentation of my culminating experience for the NURS 613 course, Introduction to the Clinical Nurse Leader Role. During this presentation, I will be identifying and discussing key issues that I have identified throughout this course. When I began this course, I had a general overview of the clinical nurse leader role. However, throughout this course, I have gained a deeper, more comprehensive understanding of the CNL role and how its concepts apply to actual nursing practice situations. Interacting with my professors and fellow students has further expanded my knowledge and understanding of the CNL role. The clinical nurse leader is an advanced generalist who functions in a variety of roles at the microsystem level. Microsystems are the building blocks of all health systems. Clinical nurse leaders can function in the microsystem using the three core processes of leading, which are building knowledge, taking action, and reviewing and reflecting to promote change while functioning in a variety of roles. The roles of the clinical nurse leader include advocate, member of a profession, team manager coordinator, information manager, systems analyst, risk anticipator, clinician, outcomes manager, and educator. The microsystem of interest for key issues in this presentation is an outpatient surgery center. This surgery center has 8 operating rooms. The staff include 31 registered nurses, 8 surgical technicians and orderlies, 2 anesthesia technicians, clerical support staff, and of course, the surgeons and anesthesiologists. The surgery center performs approximately 4,600 procedures and surgeries annually, serving a population of both adult and pediatric patients. Rated as one of the highest fears among surgical patients, postoperative nausea and vomiting, or PONV, remains one of the most common post-surgical complications and is associated with negative impacts on the patient and the healthcare facility. Research has shown that PONV leads to increased length of patient stay, increased costs to both the patient and the healthcare facility, frequent readmissions, and decreased patient satisfaction with their surgical experience. Patients experiencing postoperative nausea and vomiting is the focus of key issue number 1. In this situation, the CNL functions as an advocate, systems analysis risk anticipator, and clinician. When I first became aware of the problem that our patients were having with postoperative nausea and vomiting, I knew something had to be done to decrease the incidence of PONV and improve the patient's experience, and began advocating for change. This began with talking about the need for change across the perioperative services areas and disciplines to improve patient outcomes. An analysis of our microsystem was needed to identify current practices and barriers to implementing evidence-based practice guidelines. As a clinical leader, I work to identify interventions that will impact the outcome of care. In assessing the surgery center microsystem, key issue number 2, a lack of staff knowledge regarding current guidelines for the treatment and management of PONV was identified. In addition to being a patient advocate, there was a need to advocate for improvement in how our healthcare system provided care and elevation of the nursing staff's delivery of care based on current guidelines. Functioning in an educator role as a staff nurse, I collaborated with an interdisciplinary team to begin to assess the nurse's knowledge base and begin development and implementation of an educational module for the nursing staff. After assessing our microsystem, key issue number 3, our practice was not evidence-based, surfaced. Current practice is based on old guidelines. As an advocate, after identifying the clinical issue, I teamed up with another RN to research and discover what the current evidence was for the treatment of postoperative nausea and vomiting, to share the information with other healthcare team members, and to begin to develop a plan for the implementation of the current guidelines. In addition to changes in nursing practice, I am collaborating with the head of the Department of Anesthesia to develop updated postoperative order sets that are in line with the best practice guidelines. Key issue number 4 was ineffective communication among care team members. Specifically, if there was a patient that was identified to be at high risk for postoperative nausea and vomiting by the pre-admission testing nurse, there was no process in place to communicate this information with the pre-op or post-op nurses. I developed a clinical note that the pre-admission testing nurses write for the anesthesiologist to communicate patient-specific information and is available to the other care team members. However, due to time constraints, the nurses do not always look at these notes, so a better system for the easy identification of patients at risk is needed that all care team members can easily see. As a team coordinator, this is a project that I am currently leading. Key issue number 5 was the ineffective use of the electronic health record for PONV risk documentation. Functioning as an information manager, the CNL uses knowledge of the current EHR to develop a plan to identify patients at risk for the development of postoperative nausea and vomiting, and as an outcomes manager to use the electronic health record information systems at the point of care to improve healthcare outcomes. So what this means is that I am looking to implement a postoperative nausea vomiting risk score, integrate the score into the nursing practice to help identify patients at risk, and embed the score into the electronic health record. My SMART goal is based on key issue number 2, lack of staff knowledge. A SMART goal is a goal that is specific and strategic, measurable, attainable, relevant and result-oriented, and time-framed. The application of the SMART goal to key issue number 2, lack of staff knowledge of current guidelines for the treatment and management of postoperative nausea and vomiting would be as follows. The goal is to improve perioperative nurses' knowledge of the risk factors, prevention, treatment, and management of postoperative nausea and vomiting in post-surgical patients. This would be done through an administration of an educational program based on the current evidence-based practice guidelines. Change in nurses' knowledge will be measured through administration of a pre-test and a post-test. The expected attainable results are that there will be an improvement in nurses' knowledge. This is relevant as despite advances in anesthetic and analgesic agents, PONV remains a significant problem for surgical patients and among the most common anesthetic complication. Evidence shows that patients fear postoperative nausea and vomiting more than pain. As a CNL student, I will develop and present an in-service to perioperative nurses at my outpatient surgery center with testing of knowledge by a pre- and post-test. Coordinated with the site director, I plan to present the in-service and test at the monthly staff meeting in either January or February of 2015. In conclusion, the summary of key issues to continue in the next CNL courses are further education and knowledge testing, dissemination of evidence-based practice guidelines for postoperative nausea and vomiting, continued collaboration with anesthesia to revive postoperative orders, development and implementation of risk assessment tool, integration of the risk assessment tool into the electronic health record, and measurement of outcomes such as length of stay, patient satisfaction, and readmissions as allowed by the IRB. The key to success in the reduction of postoperative nausea and vomiting is a multifaceted approach. These are my references, and I thank you for your time and attention.